Good. So I will get started because I know time is of the essence. I'm Jessie Sanders from the American Cancer Society, and I have the pleasure of helping to moderate this breakout room for colon cancer screening for the PDSA project. And we are going to have two speakers that are going to be able to share what they're working on with their project at their systems, and you guys are able to ask questions. And as Meg said, if you could please use the chat function to ask any questions, or you can raise your hand. Again, it's at the bottom, reactions with a little smiley face in the plus. If you click that, there's a hand raise function there. So please ask any questions that way, but we definitely want this to be interactive so you can learn from each other. And we have Deborah Burgess from UC Davis that is going to share on her project, as well as Tiffany Mazzi from Centricare St. Cloud Hospital in Minnesota. So we are going to start with Deborah. Deborah, are you ready to go and share about your project?
Yes, I am.
Great.
So I'm happy to be here, and I would like to start out by saying, as the quality coordinator for our cancer committee, I was delighted to see this project come out. And our chair of our committee and our CLIP was very supportive in really getting involved in doing this. And we did select to participate in all 4 cancer screenings. And the materials that were sent out were really fantastic, I'll have to say. And I was, I guess, incentivized by looking at, and I did go back and track our data, even like was presented back to 2018, 2019, and 2020, so we could really get a full picture of what was happening with our program and really measure what happened in 2020 during the pandemic compared to 2019. And that was really helpful for us when we started looking at where we needed to be, what our intervention should be, and help guide us. So we were one of the fortunate, I think, cancer programs that even with our colorectal, we did see drops in all areas, some more than others, especially like cervical and breast, which is was a little surprising. Colorectal, we had about a 4.5% decline, but we saw an identical drop starting back like with February 2020, and it really plummeted to the low in April. And then we started seeing a comeback, later on through the year. And we did try to get ahead of this a little bit, seeing what was happening. Especially with the pandemic, we did close our hospital to elective procedures, which really was, the facilitating factor. And then we had patients that were apprehensive about coming in for screenings. And of course, especially with something like colorectal screenings, even though we do offer the other type of methods for doing the occult blood screenings or the home kit, the Cologuards, and this kind of thing, and promoting that, we weren't seeing the numbers jumping back and so forth. So we got on board early, went through what can we do to enhance this. And I think some of the things that were really helpful, we do use Epic for our electronic medical record. So we got busy putting together our Healthy Planet health maintenance tools so that both our primary care and our specialists could see, and they were getting reporting on what was happening with their patients. In California, we have a lot of HMO insurances. We have patients that we manage their care. So we did, that's where we directed our attention as far as who are we responsible with. We service our, we have a area of probably over 6 million people that we capture for our cancer center, and then the greater Sacramento area for primary care. So we do see a high volume of patients that come to see us for primary care and our specialty services. So we did definitely promote and improved reporting physician, so they can go on and they can pull up for their clinic and their individual patient lists as far as where they are for meeting the health maintenance requirements. We got very busy on improving our reminders for patients. And one of the things we first started with was with colorectal screening, and we actually had the medical assistants in the clinics reaching out, looking at the reports, and then looking at the health maintenance, and then calling patients, doing a direct call to see, you know, letting them know they're overdue for their screenings, doing some education, and then actually working with them to screen, you know, to schedule that and get those referrals actually entered. And then what was really nice is for patients that were then due to come in to see their doctor for maybe it was their annual, there was a lot of direct one-on-one education. The options were discussed for which way they could get screened based on maybe their risk or family history and those kinds of things. We also took the approach of also rolling out some small social media with the Cancer Center, similar type of information to the specialists, because we do a lot of our, you know, surveillance for recurrence. So cancer screenings are really important for that population of patients as well. And then I think to address some of the barriers, we did have to look at as the demand was coming up, you know, to recover, not only close that gap, but our goal is to actually try to reach that 10% above and beyond just returning. So we did have to expand access a little bit to be able to provide, you know, that accessibility for appointments, and look at, you know, trying to expand our templates for, you know, with colorectal would be for, you know, the GI specialists, so that they can be doing these procedures. And, you know, they start up right at, you know, 7:30 in the morning for first colonoscopy up through, you know, 5 o'clock that day. So our volume has really come back, and we are very fortunate that we are meeting our target and have now exceeded what we needed to do. So it's been a very successful project for us.
That is excellent to hear, and we appreciate you sharing that. Thank you. It sounded like you really did have quite a few interventions that you did, like Meg said, not just focusing in one bucket, but kind of doing some strategy across the different buckets of, you know, focusing on, you did assessment and feedback. So you made sure that your staff had reports on those patients that were overdue. You made sure that they were able to see those with your EMR updates and the health maintenance work that you did. To be able to see who they had and how they were doing, what their rates were, which is an evidence-based intervention there with assessment and feedback, and the client reminders, having your MAs call directly. And then that one-on-one education we know is huge when it comes to any cancer screening, building that confidence with those patients and having one of their medical staff really educate them and encourage them. So it sounds like you did an excellent job, and you're continuing to do an excellent job. Does anybody have any questions that they would like to ask at this time? Let's see, Paula. Hi, Paula. You're actually at one of my facilities. So hello, Paula. How do you anticipate the ongoing pandemic will affect the results of this study? There are currently restrictions on elective procedures in many areas. The numbers may not reflect improvement over last year. Is there any thought about continuing the study after the pandemic is over, if ever? So this might be a question for Heidi. We do have Heidi in our breakout room. So Heidi, do you want to comment on that?
Yeah, it's a great question, and we're starting to hear that more and more from people. So thank you for asking, so we can make a comment about it. We're working with the Commission on Cancer and the National Accreditation. Well, I guess you don't care about NAPBC, that doesn't relate here. We're working with leadership to see about whether to extend this into 2022, and they're going to have to give thought to that. But I would say that you can continue to do the PDSA. It's going to be available. You can use the red cap for as long as you want. I don't think it necessarily would shut down, or you can use a piece of paper. Or there's also a fillable PDF that can be used to keep track of interventions and the monthly screening numbers. The key question you're really asking, would you get 3 kinds of credits, 3 standards worth of credits for it? And that won't be up to me, that will be up to the leadership of the accreditation committee and the Commission on Cancer leadership as to whether they want to focus on this again for another year. So you could certainly get credit for quality improvement if you're measuring something and then you're closing that gap. So you would get credit for the quality improvement standard if you continue to do this. Whether or not this will qualify for screening credit, or it would, if we close the study, then you couldn't get study credit for it. But that's something that's under discussion right now, and we'll get back to you and keep looking in the Cancer Program News for that answer. Thank you for the question.
Thank you, Heidi. Does anybody else have any questions or anything they would like to ask Deborah about what she did with her program? Or any other questions? If not, I would love to turn it over to Tiffany Mazzi to share what she did at her facility and hopefully share some things that others might take away from this as well. Go ahead, Tiffany. Oop, you're on mute still. Down on the bottom left-hand corner.
There we go. Can you hear me now? Okay. Yeah, so our program, we really lucked out when the initial study began because our facility and organization also felt that the gaps in preventative care and screening was of importance. And so we as an organization had initiated a "It's safe to return, we're ready to care for you" type of program for preventative and screening. And so we collected a lot of those interventions for this project as well, because the time frame was right, and we wanted the study to reflect all interventions, which was mentioned earlier. And so we do our best to try and monitor things across our system that may be applicable to add to the study interventions and stuff, so that we're not missing things that could have potential impact. When we first started, it was a lot of, so from our organization program, it was a lot of getting the word out. And so we did everything from social media, websites. We did letters to patients, and not just being aware of our community. We were able to also send out many letters to our Spanish speaking and Somali communities. So we did our best to be aware of who we serve and how we can best serve them. We did lots of things like billboards and newspaper articles, radio stations. Again, just getting the word out to come back where, positive messaging to have those preventative appointments and screenings. And then we did a great deal digitally. And so everything from our website for the organization, that was the first thing you see when you clicked onto our site for many months and stuff. Again, we're here to care for you, and with links on how they could schedule appointments. Then from our own cancer facility, we also had more specific ads that we had sent out. And so we did a lot to different types of newsletters that we do. And so there's one that goes out to every employee of our organization. And so in that way, we're able to capture those specialty and primary care providers because they're getting the same message. Some of the challenges that we initially had with the colon part, we also did multiple sites. We're doing breast and colon. And just kind of comparing the two of those, it was a little trickier starting in this time frame when our colon cancer promotion was back in March. And so the positive side of that is that we were able to utilize a lot of those resources and push them out again to the community and stuff. With the changes of the age for the colonoscopies, which happened right in the middle of all of that, And then we also, because of the breast cancer stuff coming up here for October, we sort of piggybacked our colon stuff on any messaging that we also sent out to promote our breast screening. So we really tried to, we felt that all screening is important, even though we're measuring very specific parts of that. And so anything that we could send out to add that little extra piece to it, we did. From our newsletters that we sent out, some of them were specific to our cancer center patients' families directly from our center. Some were a more global digital process that anywhere we could get our information out in different topics, we did. We also sat down and looked at any events that were coming up throughout the next months to the end of the year. And so, for example, we had just recently Pride in the Park with the LGBTQ community and a Relay for Life. And so we took those opportunities to change whatever our promotional style is going to be for that event to be specific to cancer screening, so that we could really push that out to the community. In terms of other opportunity pros and cons, we definitely are far more successful in reaching a larger amount of people when we use our digital type situations and stuff. We have every screensaver in our entire community that has about screening. We have every digital billboard, you know, where it kind of runs through all the different information and stuff that has our cancer screening recommendations and stuff on that. And that goes beyond just our immediate facility. We have a lot of outreach facilities. We cover like about the most of central Minnesota, and so our reach is quite broad to get this information out. Our numbers only reflect those at our facility, but we are sending the message out, so like our outreach numbers, you know, are also something that we're looking at kind of behind the scenes. Aside from that, so thinking about capacity, as was mentioned before, that was one of the very first things that we looked at, because we weren't sure where our like realistic expectations were, especially with the study. We didn't know if 10% was 10% too much, kind of a thing. And so we also partnered with our breast center and then our areas that do the colonoscopies, just to double check that if we did have some huge influx, which would be awesome, of patients, that those were realistic expectations and they weren't going to be postponed to get screened for, you know, a few months or whatever. And so we kind of checked that off the box right away and stuff to make sure. And we do have the capacity. We have several different sites that our patients are able to get colonoscopies in addition to our mammogram program and stuff. And so that really allows us to hold the need from our community.
We're going to be routed back in about 45 seconds, but did you have any final thoughts? I'm sorry, I didn't want to cut you off, but
no, yeah. So like I said, we had our approach was to get the word out as much as possible, make sure that we had the capacity to take care of it, and not forget about those unique populations in our area, like the Spanish and Somali communities.
Yeah, I love that huge strategy that you had for just kind of canvassing every which way, that not only provided communication out to your patients, but also your staff were seeing it everywhere. So it really provided education in both areas. So that's pretty amazing. We're going to be all tossed back to the main room here in a couple seconds, but thank you so much to both of our panelists, and we'll see you over in the other room.